Sorry, I didn't bring any bacon.
Culinary consultant to the REMAC. Unfortunately, the bacon request seems to have been denied. I'm sad about that. All right, with no further ado, let's start looking at the September minutes. Has everybody had a chance to review them?
Yes, and I think the motion for approving the SCT training should probably read more like that the proposed curriculum, or sorry, the proposed training is approved based on the previously approved curriculum. Does it state that the proposed curriculum approved as previously approved? So we voted on it twice.
I motion to approve that.
Jay, you have the correction? Correction received, thank you.
Yep.
Any other correction? All right, seeing none. Motion, second. Thank you. All in favor? Excellent, thank you. Correspondence, excused members, that is from last month. That was last month. Why do I have last month?
Stand by.
Consider that a public health education.
There's coffee ready and everything.
I need Dr. Bosco to do some work for us, so I can't do that. It would be bad. There we go. We have a correspondence here from Tracy Weir, the Assistant Chief Supervisor of the Waterford Rescue Squad, informing us that Dr. Kelly will no longer be their medical director and that Dr. Ushkow has agreed to take on that role. Dr. Ushkow, congratulations for your new role at Waterford.
Thank you.
Awesome. All right. Traditionally, we have always voted on whether or not medical director changes are appropriate. Therefore, I would suggest that we follow that same pathway that we always have before. Motion made by Dr. Doynow, seconded by Dr. Rathard. All in favor? Any opposed?
I'll abstain.
He's a vote.
Yeah. Excellent. We will note for the record that we know Dr. Ushkow well. This is committee reports from the academic committee. I anticipate something very brief from Dr.
They will be relatively brief. Brink County is having an EMS day on November 13th, 8:30 to 5. HCME credits and any lunch, $25 if you do an event, $30 if you don't do it. We went over AHA updates, which really isn't very much. Our protocols are essentially compliance. And let's see, we just talked a little bit about there is no formal turnaround document. Dean happened to mention that basically data needs to be entered, but it's basically the medical director saying that everybody is
I'm sorry. Can I
Want
just
to correct that?
Yes. There is a formal, the document is on REMO ALS. It's a formal document. It's not every individual has a turnaround document. There's a prefabricated turnaround document, a re-credentialing document that every agency has. It's on REMO ALS, and it's completed by you keeping the data up to date. You simply print it out and sign it.
Okay.
Okay.
I'm sure the confusion will resolve when everybody takes that document. That's it. Basically,
Okay. Thank you.
we remind everybody that there's a meeting next month, but not the following.
There will be a meeting next month, but not
December,
the
but
following.
not January.
Yes, okay. Thank you. Actually, we could do that now as well, that we should actually have a motion right now to not have a meeting in January for ourselves, and follow that same schedule, which I think is very reasonable. Made, seconded, all in favor? Excellent, thank you. All right, Remsco, anything of note from the Remsco? Jeff, you want to bring anything?
We're gonna be a little bit better with minutes and meetings and stuff, and that was a big discussion. There wasn't a ton to discuss there.
Gotcha. Yeah, there was some discussion about making sure that the program agency and the council both are as open as possible. And as a result, there will be more minutes available should anybody choose to read them. CMAC, our meeting is going to be next month, as all of you should know from your emails, but I think it's time for a little congratulatory round of applause. Dr. Goynow, who will be our new chair of the CMAC. And for the first time, the CMAC will be led by somebody from upstate, which is huge, absolutely huge for us. So, thank you. SEMSCO, also in December. QI, Rob?
QI, we looked at response times in the region over the last year, and no major surprises. Those people having much longer than expected response times had much longer drives. So, not the most to put out. As far as next year, looking at STEMIs, probably on a quarterly basis, trauma, response time and treatments, and then particular topics, anaphylaxis, MFI, particularly how often do we end up innovating with MFI with just the sedative versus the paralytic. And then we're going to relook at the CHF data that we did earlier in the year to see if there's any change once people do some training. And we found that apparently the letter that we sent from the MAC to the docs never got forwarded to the services. So we'll try that again with a copy sent to the service director. Did we miss a comment?
That's it.
Okay.
It's forced.
Anyone has any particular pet peeves they wanted to look into, let me know.
Okay, thank you. And actually, Dean can share the response data with anybody in this room that chooses to. Because it doesn't have agency codes removed, because that's the way it was brought through, I ask that you review that data here, and then we'll shred it afterwards, so it doesn't go out into a public forum. However, at the same time, you know, all of this data can be reviewed by any of us at the tip for quality assurance purposes. It's very interesting as we looked at a couple of the agencies that literally is the way Rob said, places that take a long time to get to. It takes a long time for ambulances to get to. It's not really surprising. So, all right. Talk. There's no report. Tim apologized. He's on a DOH conference call right now. We have no updates for BLS interventions, no ALS upgrades, and a bunch of BLSFR updates, which are reasonable to expect given the change in language for the DOH. Public access defibrillation, all of these applications have been reviewed and are in good shape. New business, AHA update. Don, you want to just spend a little time on that? Just
Sure.
very briefly for the group.
I can pull it up again and kind of go over it. We're really pretty much in compliance. Let me see if I can find it.
Did everybody in the room get the Amal Matu podcast that I sent out and have a chance to listen to that? Because it's I think 7 minutes, and it says it all pretty much in a nutshell. And it's basically what we're already doing. No vasopressin, get patients into the cath lab quickly. Post-arrest patients should go to places with a cath lab. Something we're not all doing, which is post-arrest patients should go to the cath lab. Continues to be a pet peeve. We'll continue to be worked towards. We'll see how that goes. Push hard, push fast, between 100 and 120.
Yeah, I mean, basically,
Don't push too deep.
that is it in a nutshell. Don't go too fast, don't go over 120. You kind of mentioned that. Don't go too deep. Really, there's not much. I mean, we're in compliance with everything. Hypothermia pre-hospital is not recommended. There's nothing exciting in these.
The only thing that's in the AHA update that we are not in compliance with is they do not recommend broad distribution of naloxone for opioid overdose.
Right, it's kind of crazy.
Oops. Well, the reason is they're looking for level 1 evidence, right? And there really isn't any because oddly enough we haven't distributed saline out there to see if it would have an equal effect. So there's been a lot of commentary on blogs associated with opioid overdose about the Heart Association's process and inclusion.
Really, that just a corollary to that, is Mission Lifeline picking up and assisting with getting the cardiologist to understand that post-RASCs that don't show a STEMI still should go to the cath lab?
So there is primary gain from Mission Lifeline and there is secondary gain from Mission Lifeline. You're touching base on secondary gain. So the primary gain will hopefully be follow-up consistently through the system with what happens in the cath lab getting back to EMS providers to bring the patients to the cath lab. Happens consistently at only one of our facilities, and now that's been built in as one of the deliverables for the Heart Association for Mission Lifeline. One of the things that's going to be a secondary benefit, though, is the ability to continually stimulate conversation with the cath attendings about bringing patients to the lab after ROSC, because very clearly it's indicated medically. It's the right thing to do, but there are a number of cath attendings that are extremely concerned about the way that the Department of Health collects mortality statistics. And that's something that actually was changed for cardiothoracic surgery when they started doing CABGs years ago, and remains exactly the same for cath. So if you get a couple of bad mortalities as a first-year cath attending, it colors your appearance for years. On the other hand, with cardiothoracic surgery, your first 3 years of practice, your data is aggregated with the rest of the people in your program and doesn't go in individualized to your name. So there are a lot of different potential options, but the state wants to continue to collect the mortality statistics around cath, and that's continued to put the young cath attendings at odds with taking complex cases like post-ROSC to the lab. We've had a couple of discussions about this, to say the least. We will continue to have more. This is the right thing to do. And I urge each of you, when you're in that position with a cath attending, to continue to push that, because taking someone to the lab post-arrest is very clearly the right thing to do in the literature. Now the Heart Association says it too, so we've got one more piece of ammunition. So,
Mike, did we, on the Mission Lifeline Committee, did we mentioned this to Foster, didn't we?
loud and clear.
And what was the response? Was
No.
there, even though we could put some parameters on that subpopulation, he was not receptive to what, I don't remember his response.
The Department of Health was not receptive. He insists on continuing to collect mortality data. Acknowledges the fact that mortality data collection in New York State doesn't change mortality in New York State, has done nothing to alter outcomes. Acknowledges that there have been many papers written that say that mortality outcomes in states without reporting is the same as in states with reporting. And they also were the first people to say the only people that ever come looking for these data are the press, which is a very odd bedfellow to have, but they were not interested in considering dropping the reporting. It's a complex situation. I don't know what the history was behind it. It certainly has the potential to injure our patients, unfortunately. But they believe that it's also being protective at some level, even though it can't be shown. So. Anything else? No? Okay.
Just if anybody needs it, a paper by Reynolds in 2010, 2011, probably the best data for this if you wanted cardiologist journal circulation, I believe, looking at post-arrest cath versus no cath and outcomes. Pretty obvious, specifically in VFib, VTAC arrest.
Well, the issues are clearly laid out by AHA, plus all the research. The only problem is you have to get the cardiologist to look at it. That's for a different forum than here. So the pre-hospital people are doing it right, so we can move on from the subject. I was just trying to look at this from a systems perspective. It's great that EMS does it right. It's too bad we can't get the cardiologist to do it right.
One step at a time. We'll get there. We'll get there. This is going to give us 18 months to be able to improve what we're doing now and see whether or not that can be our next step. So hopefully we'll get there. Quick update on the syringe epi program. The syringes will be in Rochester and Arizona next Monday. After that, once those syringes are there, the guys in Rochester will take the pictures they need, do the finalized training that they need, and get the information out to everybody at that point, and orders will be able to be moved forward. We're gonna finalize the training on Tuesday or Wednesday.
I spoke with Ben Sessenbach yesterday,
Excellent.
and they are hoping to have training materials out to the agencies that have signed on by the first week in December. Once the syringes arrive, they have to go to Boundtree for packing.
That's the Arizona part.
Yeah.
Yeah. So Boundtree's doing the packing out there, but also doing the distributing, which is something that they have a network to do, so that should work out well. I wrote REMAC schedule for 2016 into the agenda with an interesting question for everybody. Do we need to meet every month? Or should we meet every other month with the expectation that we take January off already, we take July and August off, so that only leaves us really with 9 months to take a couple of other days off, or a couple other months off. What do you think?
That probably isn't unreasonable. I mean, if there's some issue, we can always end up having an urgent meeting. Usually we don't have a whole lot of, we don't have things that are on the table that are so time constrained.
So if we look at February, April, June, and then do September, November, December? Or how should we do that? So I think 3 and 3 makes sense.
Why just not keep it on the even months?
Even months except August.
To do it that way.
Do a meeting in August.
Or do a meeting in August?
What was that?
Or just do a meeting in August.
No one will show up. It's not worth doing anything in the summer. I agree with having less scheduled meetings.
Yeah, it'd probably be easier if you just stick to even months.
I hear crickets out there.
Let's schedule one for February 29th just to say we did.
It's an excellent idea. It's an excellent
Well, if
idea.
you-
That'll actually be the meeting you're responsible for snacks. The rest of it still belong to Sarah.
Mike, if you wanted to get 6 meetings in, you could do February, April, and June, and then the last 3 meetings, instead of doing August, October, and December, you could do September, October, December. So you avoid July and August. If you wanted to get 6 meetings in.
Do the bylaws have any specific number of meetings we have to have per year?
No, just that we have to, the bylaws that we're gonna talk about shortly would include that we need to make sure that you're making a set number of those meetings.
Sam's proposal is a decent one.
I think so. February, April, June, September, October, December. All in favor? Excellent. Now, something we need to check very quickly. Dr. Vogel, will you be able to make all of those meetings? Or you're responsible to find all?
For the most part. I won't be here next month, though.
Make a motion to
Yeah,
cancel a
let's
meeting.
I'm out of town.
Is there a freezer here?
You have a little toaster oven, you can bake them up.
We will take nominations to be responsible for food in Sarah's absence. Okay, so next year we'll do February, April, June, September, October, December. Ken?
We're gonna make academic follow the same, or ask academic to follow the same schedule.
I would suggest that.
Well, we can do that. We have enough academic members that stuck around. So what do you guys think? Doing the same schedule? Everybody in favor of that?
What was the schedule again? I wasn't paying attention.
February, April, June, September, October, and December. It'll be 6 meetings.
Sure.
Now we'll have to change our bylaws as to how many you need to make.
I don't know what it is.
No, it's 67%.
6, so.
Do academic and
You
honors.
need to make 4 out of 6.
We can accept that only if Dr. Daly brings baked goods.
All they bake is bacon.
All right, so if everybody's in favor after academic, we'll do the same. Jay, if you could put that amendment.
Got it.
Thanks.
Okay, excellent, thank you. And obviously, if we need an additional meeting, we'll hold an additional meeting. There is a pilot program that will be run from Suffolk County. They're putting it together now. They actually did a pilot program that actually was Bob DeLogge's graduate thesis down there on 12-lead acquisition by basic life support providers in 1999. He did it in conjunction with Mark Henry, who at the time was chair of the CMAC. That pilot project did not get converted into scope of practice in New York State, unfortunately. And now we're entering into this Mission Lifeline Accelerator. We only have a few areas within the region where we only have basic life support response, but there are some gizmos out there that can quite accurately obtain 12 leads with relatively little confusion or confounding. Bob's pilot is going to be to do basic life support 12 lead acquisition. He's bringing that to the CMAC in December. I think this is something that would be very well suited to being added to the scope of our BLS practice for very specific agencies. I'm thinking Duanesburg in particular, folks on the 22 corridor in Rensselaer County as well. We've actually seen one of the devices at Albany Med. The guy came over to show it to us. It's fascinating. It's a little box about that big. You wet the chest, you put the box in the middle of the chest, you then wrap a belt around the body that holds it in place. You then put a lead in each of the axilla and slip one under the person's belt. Push a button, it marries up to a smartphone and sends the 12 lead to a physician. It can't be used without sending the 12 lead to the physician, so it gets immediate and complete oversight. We actually had a BLS provider from, where were they from, Adam? Cobleskill. Yeah, from Cobleskill Ambulance, who happened to be in the emergency department at the time, just slightly to the left of nowhere. But we had somebody from a BLS agency there. We had him just put one on me, and it put it on without a problem. Sent them out to Steventown, actually, to talk to the guys there, where they met with the Steventown fire chief, and they reviewed the technology, which he thought was really interesting. And no less than 72 hours later, Steventown had a STEMI, which they had probably a 20-minute longer door to balloon than they would have if the EKG had been acquired in Steventown. Now, that's probably the only STEMI they're going to have for the year, but it was kind of interesting that it presented that way.
Mike, how does it decide which position to send it to? Is it going to be specific or?
It actually would be one of these things where if we're going to do it, there's two things that it does. This device itself automatically sends its 12 leads to both its central hub and also anybody that you designate locally. We would probably designate one local location for these. I'm the medical director for Steventown, so I'd probably just have them come to us because it's easier. Duanesburg, if they were going to participate, we'd have them all go to Ellis because Ellis is going to be the one that's going to be taking those.
Those go on our receivers that we already have?
No, this is actually going to be a separate gizmo. There's one that will work for the receivers we currently have. That's actually, I believe, about $8,000. These are $1,000 a piece. So there's not much question in terms of the finances of it. It would require something different.
So technically, there's nothing that says that we couldn't just devote an email address that everyone had access to, and do it that way at a central place. But you can, so they send it always to their physicians actually in Israel, who read them all 24/7. In Israel, they use this. They have it for people, and then they send an ambulance out with a doctor and TPA. Go out and TPA people.
Oh, yes.
And bring them back to the facility. But you can send, so they'd always get sent to them, but you can sort of divert it to any other email address you want as well.
The thing that's important from a Steventown perspective is almost all of the patients in Steventown actually go to Berkshire Med. This is one of those things where you actually would delay a reperfusion by a significant amount of time with that patient going east, whereas if you can turn that patient and have them come west instead, it's going to be profoundly different for outcomes. They'd be able to do that right then and there. Sarah?
This would require cell service, right?
About 40 to 50% of Steventown actually has some cell service. There are a couple of places that they can identify very clearly where they would be able to stop, do the 90 seconds it takes to send this 12 lead, and have the conversation with the physician. Before you have to make the decision, do you go left or do you go right? And also, when you go left or right, you meet up with a different ALS unit. So there's a whole lot of different things.
Does it give them any it doesn't give an automatic read of any sort?
It just tells them whether or not, it gives them enough information to know if they acquired a good signal or not. It doesn't tell them, it doesn't do that.
Printout.
So the read
No,
from
does
the
not print.
Israeli physician is done within 15 minutes, and that gives you a freak out. You know, that'll give you a, you need to go to the hospital now sort of thing. But I think the way we were sort of, after looking at it, I think it would have to be, if you acquire a BLS 12 lead, it automatically goes with a phone call to somebody else to review it in real time.
And that's actually built into the protocol
So
as
you
well.
could send it to the email, and as an email, it's a PDF essentially, so you could print out the PDF.
You just have to know it. They have to call.
Right, they'd have to call you, and
They have to call
the way I would look at it is you'd pick up call the remote physician at whatever hospital they want to talk with, and then you would know to go, okay, hold on one second, let me bring it up on the email.
It'll be rare enough that the pain in the butt will probably limit written interpretations.
What was that, Rob?
So it'll be rare enough that the pain in the butt of doing that may be limited.
Right, right. I don't think this is something that's going to affect a lot of patients, but the patients it has the ability to affect, it's going to be life-altering.
Yeah.
And they're planning to do that on every BLS agency in Suffolk, or what is it?
No, what it is, Suffolk County is a community with lots and lots of agencies that are part-time ALS. So a lot of their agencies will have a life pack 12 or 15 with transmission technology that for some of their crews will basically be a really big, expensive AED. What they're planning on doing is teaching those providers to use that AED to acquire a 12 lead and then transmit that 12 lead.
So this device we're just gonna use up in this area.
It could be used for this area for places with less money. So so the idea behind the pilot is, can basic life support providers adequately be taught to acquire and then transmit a 12 lead? When we look around the techs that we teach in our emergency departments to do this every day, of course our BLS providers can do this. So what I'd love is just support from this group for our joining this pilot if that opportunity becomes available after the CMAC discusses this in December.
Just two things I want to say.
Bruce.
First, unplug your ears. I will tell you that there has been BLS providers acquiring 12 leads in this region for a very, very long time and transmitting them.
Don's the chair of the CMAC. He is not an employee of the Department of Health. He does not have to plug his ear.
Okay, so anyway, that was just part of part one. That's
Unplugged.
done from Dave Pratt era, did that very long time.
He probably had one on the back of his pickup truck.
So anyway, so we certainly have proven that it can be done, and it's still being done all the time, even if it doesn't make it to the paperwork. The other part is, I think that it would be critically important for BLS is doing this, that the patient ends up at the right hospital. That's the closest cath lab facility. I don't care who takes the phone call, if you have a central receiving station with a central physician, but I think it would be very important that by time that patient ends up going to the closest cath lab.
I think that's very appropriate, Bruce, and I think we've got to remember that. Because along the 22 corridor, the closest cath lab in some cases may be in Albany, but for a significant portion of those patients, it's going to be Samaritan. And for those patients, I think that's something else that comes back to a topic that we've talked about briefly here, is what's the best way for a doc at the med to help you activate your cath lab if we get that call. So if there's one person that's getting those BLS 12 leads, we need to make sure to be able to get that information to you so you can get your cardiologist coming in. Absolutely. The right thing is closest appropriate facility.
I wasn't just thinking Samaritan, I was thinking even if you're ending up going in a different direction, it could be leading away from our region. It all depends on where they see the spread.
There's no cut
I'm trying to do that. I suppose we could get somebody in, going up to Glens Falls, certainly. Yeah.
So we just have to be cognizant.
Mhm.
What happens is we all receive a phone call and we just fall into our usual pattern of thinking.
Mhm.
We don't think about directing where the providers could go. We just give medical orders and say, we'll see you in a while.
Yeah, no, that's very true. Good point.
At least for the purposes of a pilot program with these agencies, for this setup, it would be Samaritan Albany Ellis, or two meters.
What's the concept I'm throwing out?
Yeah, we just have to be careful that it broader.
Is
And-
obtaining an EKG outside of the scope of a BLS provider?
At the moment, they're probably.
In New York State it is, although there are other states that do it regularly.
Obtaining it or interpreting it?
Interpreting is outside the scope.
That's,
Yeah,
that's,
obtaining.
No, I don't remember that being in the scope of practice of a monkey control these providers. Rich, you remember that?
Scope of practice is specifically designed to be flexible to meet
I'm
regional
asking.
needs, and there's an actual disclaimer in this, in the scope of practice document that provides for regional variations, because there's an understanding when it was written, the medical practice would change and that people would have to change within areas according to what their standard of care was.
I don't think it should be. I think it should be within the scope of practice. But I'm saying, if it's within the scope of practice and then they're not interpreting, do we even need the pilot program?
Interpretation is out. And I think, I'll go back and reference that, I believe there's actually specific language to that, but acquisition is possible.
The Department of Health has already told Suffolk County and Scarsdale Ambulance, who asked for this as well, for the same reason, that they have the equipment there, can we please use it? In both cases, they've been told they need to do a formal pilot. So that's why Suffolk's putting the pilot together. So, clearly there are some places out there that have the technology that would be able to do this for other reasons as well. So, motion for participation? Adam?
Sure.
Thank you. Seconded? All in favor? Don twice? Okay, thank you. Mission Lifeline update, another executive board call tomorrow, I believe. The plan is to get a core group of interventionalists together for a call next week to hopefully finalize a key set of door-to-cath protocols finished. We thought it was done, it became undone, and now it's been opened up again for review. One element that we may have talked about briefly is the idea of what needs to briefly stop in the emergency department and what should just go straight to the cath lab. The cath attendings would like to make that an age limit, so that at 75 you briefly stop in the emergency department for a review of whether or not you're appropriate to go directly to the cath lab. There's some questions as to whether they want that to be a discussion by the ED physician or the cardiologist. More to follow. I'll keep you posted. Long conversation, sorry.
Right.
Sarah?
Not so much for EMS, but your hospital bylaws state who can do a medical screening exam. And empower-wise, buzzing through the ED without actually being seen may not be legal if your cardiologists are not in the bylaws as people who can do medical screening exams. For instance, at our hospitals, it's only the ED providers that can do that. We did have a patient show up who complained of chest pain after falling down a flight of stairs. Had a 12 lead, the cardiologist was in the department and whisked that patient upstairs, and that patient was never seen by the emergency department physician. Well, it was at your hospital, not my hospital, but anyway. And yes, he had chest pain, and yes, he was having a STEMI, but yes, he had fallen down a flight of stairs. So, just check and make sure that your bylaws are okay at the hospital to do that.
I know since we're going to be interventionalists do that.
They do. Great.
Ours do too.
The ability to do medical screening exams?
Any licensed provider can do a screening exam under our bylaws.
But that's only if they divert from the ER. If they're in the ER, they need to be seen by the ER doc. But if they go straight to the cath lab can tend to see them.
They can still, I mean, it never happens in our place, but if there was an attending there to meet their patient, that would, as long as they were credentialed on our staff, it still qualifies as being an adequate provider to do the medical screening exam under our bylaws.
And at ours, it does not, because if somebody's there to meet their own provider, we have to go in and offer
It's-
them a medical screening.
I'm not sure actually if it's in the bylaws or the rules and regulations of the medical staff. It's in one of those two areas, but I think it's in the bylaws. It even includes midwives, because we have an OB service. So the patient is brought directly up to OB, and there's a nurse midwife there to receive them if they're credentialed.
Fascinating. I'll bring that up in the discussion. Thank you.
All right, I'll get in trouble, I have to say, no matter what the bylaws say, I would be very leery. It's one thing if someone is just complaining of chest pain, has a clear STEMI, but so often there can be other complicating factors that a cardiologist or anyone other than an emergency physician or a family practitioner is gonna miss, because they just don't think that way. You know, it's a hammer and a nail concept in orthopedics.
Mm-hmm.
It really needs to be
I'm a
some
firm
bylaws.
believer in the brief screening exam by an emergency physician in every case. That's not the majority of the conversation. The majority of the conversation they wanted to have is actually where there's going to be a hard stop in the emergency department. So each institution will be a little bit different, and each attending within that institution will be a little bit different as well in the emergency department. Where this is primarily is entered in, rather than how fast they can get pulled out of the department, is which of the cases should stop in the ED, awaiting the cardiologist to have a conversation with the patient, which one should stop in the ED while the team is on their way in, which one should the team already be there, and that's the other component of it. Our horse in this race, like everything else, is we want the best outcomes for our patients. The trick here is going to be to continue to work on the interventionalists and make sure they all buy into it. So, Ken.
How does that differ from like the OBGYN patients we come in that are in labor, active labor, and they're like straight upstairs? And never,
His are credentialed upstairs. My assumption would be that our obstetric service is also credentialed to a screening exam. It's something that frankly I'm going to give McKenna a call about later and find out more, because I think it's utterly fascinating.
Does it kind of fall under the same kind of guidelines as whether or not you look at the patient or not, or evaluate them or see them before you kick them somewhere else in the hospital?
Well, my guess would be that just like St. Peter's, I'm sure the folks in the Burnett Care Center upstairs are credentialed to do screening exams. It's a separate but equal institution of some sort, isn't it?
Well, if they do come to the emergency department, we actually screen them first. We have an expedited process, but we do it when we see them.
Really?
Yep. And we actually do formal transfer paperwork, because it's a hospital within a hospital.
Wow.
Care. So we actually see them do the screening exam, fill out transfer paperwork with the accepting doctor's name. It's an auto accept, and they go off. But we eyeball them fast, make sure they're not toxemic, and away they go. I mean, the process is a minute and a half. But there's been a couple of patients we've rerouted.
What I want to say to my colleagues within the partners is just this week at executive committee, there's a uniform set of bylaws being circulated and passed at each institution. So this is something that we all need to follow up on based on this conversation, because we got to make sure that it's supposedly uniform now in all 4 hospitals. So let's see what is relative to this issue, if it is addressed in those new set of bylaws.
I mean, at my hospital, it's a little bit weird because we have no labor and delivery upstairs, we have no cath lab upstairs. Who else is going to do the medical screening aside from us? We're it.
Right.
So,
Well, the only
you
place
guys
they're
have
going to go
other
is
options.
out.
Huh?
The only place those patients are going is out.
Yes.
Yeah.
Yep.
Interesting. Thank you. So, last thing I have down here for new business was a little MCI that we had yesterday, and I thought that some of the participants in that exercise could tell us a little bit about it and how things worked and what happened. Lay the groundwork. Down in Green Island, there's a facility where somebody was working on, working underneath a fume hood. In that fume hood was a hot plate, some acetone, methanol, hydrochloric acid, hydrofluoric acid, and nitric acid.
Sounds like a disaster just.
What could possibly go wrong?
No, what you're really waiting for is the punchline, right? So.
It's elemental. Go stand outside.
So, oddly enough, the acetone fell over onto the hot plate, caught fire, which burned up the fume hood, which then released the sprinklers, allowing water to fall onto this mess. Ray was there, Adam was there, Bruce got some of the patients, EJ arrived. Who wants to pick up the ball from where I've placed it on the tape?
Yeah, boss.
Right.
Initially, the report was 19 firefighters potentially exposed, only because they had walked through the water and that they know the hydrofluoric acid was broken and open and dispersed. They did not know if that happened during the fire, during the sprinklers, during the fire department's attack. Nobody knew. So the assumption was they all got it on their turnouts. That number went from 19 to maybe 30. They segregated all those people, collected them all up, stripped them of their turnouts.
So no non-firefighters were exposed in the original fire
No.
burn?
Correct, because they were all out before the water.
They knew better.
Yeah, they
knew to run.
They followed their policy. Their policy was, if
Run.
something bad happens, they meet feet.
I'm not sure it was a length of time before they recognized that this was potential. Jump ahead, way ahead. After the 24 identified people were moved, 2 other people walked up wondering what all the stuff was, kind of behind yellow tape, including SABAs, and then they were the only 2 that potentially had actual hand contact. They changed all the SABA levels, and that was a good half hour after everybody else was gone. So similar to a car accident, they just keep coming. Contacted Albany Med, see how many, because initially the fire department wanted everyone to go to Albany Med. We knew that was not necessarily a good potential outcome of any of it. So contacted Albany Med, spoke to Dr. Daly. He contacted toxicologists, and then 2 physicians were sent, 1 to the scene and 1 to Waterville, because that's where they were going for a secondary shower. And then Adam.
Yeah, so we figured out that there were about, at that time, 25 patients who had had some confirmed interaction. Colony set up gross decontamination. We did a full decontamination of the patients in the parking lot of the facility, put them on a bus, sent them to Waterville Firehouse, where they did another decontamination just in a regular shower. And then they were seen there by Kevin Collins, one of the other physicians from the Med. At that point, we started to divvy people up. We tried to keep departments together as best we could. We knew we had a toxicologist in-house at Albany Med, so the 2 patients had symptoms. So we sent them and their fire department to Albany Med preferentially. We moved 6 to Samaritan on one of the fire department buses, and then we moved the other 19 initial ones on a CDTA bus, which made a stop at Albany Med and then a stop at St. Peter's, after I convinced the bus driver that it wasn't a joke. On both buses, we put an ALS crew with full ALS gear. We essentially emptied an ambulance into both buses to keep someone there who could potentially take care of patients should the need arise. So it was overall a good thing. The reason we moved the patients to the hospital is toxicologists thought that lab work needed to be done, and there was no great way of mobilizing a lot of lab equipment and monitoring to the scene. So we tried to do the decons ahead of time. I will say, you can pass back to your individual hospitals. Thank you to all the hospitals that we contacted. Everybody was very receptive. At the hospitals, there was some question about if we hadn't done the decon, what would they have done? I'm not sure that they all felt completely comfortable that if we had just started dropping patients at their door, that they would have been able to know what to do. Once we told them that all the decon was done, everything seemed okay. So people could check on that. I think that would be the biggest thing to bring back from here. Other than that, I think it went well. A lot of agencies involved, but everybody worked together pretty well. EJ,
I was basically in the second decon area and prepping people for transport. As of right now, I spoke to Woodley Fire about an hour ago, and all the gear that was there is condemned. So we've been scrambling to try to get them gear to use in the meantime, which makes me question medical equipment, so forth. For future stuff, we may need to have that checked. The biggest thing that I saw that it's something we don't see every day, and I brought this up to a couple of people, is maybe having a reference point, whether it be on the REMO website or whatever, since there's pretty much nowhere that doesn't have the internet accessibility, just to go as like a checklist of reminders of what to do. We go to house fires every day, we know what to do there. We get a plane crash, and it's a whole different ball of wax. There's different things that come into play. I think a central point of access to a list like that, along with phone numbers, and the only other thing I could think of, I mean, it went well, would be maybe some form of a conference call between all the hospitals at one point, so everybody can discuss their, because we had to call each hospital individually and base our next call off of the last call. So maybe if you had everybody on one line, certain decision maker, whatever, it might have been a little easier.
Was there an emergency operations center that was open?
There was two different places. There was where we were.
Well, we were running a central command out of one area in the, and we were using, correct me if I'm wrong, MEDCOM to help us initially make the phone calls. The problem we sort of ran into was that the facilities, appropriately, not anything against the facilities, but they were requesting specific conversations to be had sort of in different timing intervals, you know, like, oh, well, let us know how many patients you have, and then let us know what these patients are. So we made probably between, depending on the facility and depending on who was spoken to and by whom initially, was between 2 and 4 calls to any facility that was getting patients. So I think that could have been probably sort of figured out a little bit better. But.
And I agree. I mean, I think kind of the ICS framework that sounds like it occurred on its own is fine, probably on scene management. But as far as coordinating hospitals and everything else, maybe this needs to be something we talk to emergency operations for.
Yeah, and that was something that that we probably need to think about. I agree. You know, we were trying to. You know, the guys from Holland were doing a great job of sort of coordinating, keeping track of all the patients. But it did become a little onerous, you know, it's like standing out here trying to find the right phone number for the charge nurse at Samaritan or the doc at Samaritan or, you know. So it was tough. And then the callback stuff, I mean, we had a couple interactions with Memorial was trying to help us out, so they were trying to call us back at the same time we were trying to make calls to other places. So it became a little bit cumbersome from that perspective. I don't know if there's a good centralized person or point to use. We probably did more ourselves than we should have been doing in the whole grand scheme of things. It worked out for last night, but
just to streamline it in the future, like an initial, and then establish an initial point of contact throughout it. I called back one hospital and I heard, "Oh my God, no!" And that was after we had told them that they had a couple patients. We can't do that. But I think to initiate it and have like almost like a sector commander at the hospital to ICS it up, but to make that person and updates, if we could do it on like a conference call or something.
I think your conference call idea is fabulous, because otherwise you will be playing phone tag, because you get information that changes.
And give like updates, you know, next update will be 10 minutes, so be by your phone, in other words.
We actually have the perfect pathway for that already, and Tim can bring it to the next talk meeting, because
Why wasn't the HOC
They considered
system
it?
instituted?
Well, they considered firing up the HOC, but because it was a specific number of patients, and they knew it was a fixed number of patients that were going through decon on the scene, and that this institution was getting this many, and that institution was going to get that many, and they had the counts done already, they didn't see the need to fire the whole thing.
Being on the receiving end, I think the HOC actually would have made it more complex. I mean, these were actually non-patients, to be quite honest. These were more blessings than anything else, although I did admit one for something completely different. So I agree with it. The HOC would have just been a nightmare. But the conference calls would be helpful.
You have to fully mobilize the HOC. You know, can you come up with a separate stage, maybe stage 2 HOC activation instead of,
For something bigger, sure.
you know?
Well, you and Tim can just bring that to the next meeting, I think that'd be really good.
Did you guys use, I didn't hear his name out, but Brian Woodall, and he is technically,
Brian was out of town.
he's technically the Albany County EMS coordinator who's supposed to have resources and stuff like that available to you in these incidences where he can show up and say, okay, I'll help you here, or have this form, or.
We had a lot of time, so, I mean, decon wasn't set up, and the initial calls to the hospital were, you're not even gonna see these people for 30 to 45 minutes. So that helped, sure, we weren't rushing to make contact.
But in the future, if that's not the case, and like, hey, listen, we got 25 people here in severe respiratory distress that we can get into hospitals, and, you know, having a.
If that time limit is there, calling Brian Wood is not gonna help.
No, but just.
He's
Takes him 50 minutes to
minutes
get off the hill,
away.
He's got to blow himself out of bed for that.
He qualifies for BLS 12 league.
But I agree with you. All joking aside, it may not be this way next time. They may be real patients next time, and I think this is a big red flag that we need to address now that we've identified it.
Yes.
I also,
So stopping short of it just because it didn't happen bad this time.
you know, the REMAC radio, what was it, 001, I mean, code, that would have been perfect. Just to get an idea. Used to, when we had an MCI, they would poll the hospitals and see what they could accept and so forth. And with that technology moving on, we seem to have lost that. But I also think we have a chance to more directly speak to people who will be making the decisions. Maybe, like I said, a conference call or what have you.
I think there were two things. The first thing was the initial call went to Albany Med, because the first calls to several of the hospitals were, we can't take any Albany Meds on a diversion, we're getting all their patients. Because they thought they were getting 20 to 30 patients. So that caused issues there. And to be perfectly honest with you, we do this a lot, poll the hospitals. I don't know if they have a specific contact person at the hospital, but dispatch centers poll hospitals a lot.
Yeah, I think
Who
that was
they
one
ask
of
for
the
when
things.
they call?
But I
They
don't
ask for
know.
the charge
I
nurse
asked
or
for
the?
charge
It's supposed to be the charge nurse.
Yeah.
Charge nurse.
You know, I think it was, we got different responses at different places, I'll be honest with you, because I called the most, but you know, so we got a number, and I don't mean to call you out, Bruce, but just to point something out, we got a number from, of patients that Samaritan could take. I then called, they asked if I could call back before patients go, I talked to Bruce, and I don't, had you even heard any, you had heard that all the patients were at the med and we were trying to send them back out,
I was
right?
gonna wait till that came through around to me, but
Yeah.
yeah, I also give my part. The first I heard of this was that there was a bunch of patients with hydrofluoric acid exposures with no information about it. I don't know if they drank it, if they were dying, you know, knew nothing. They were all at Albany Medical Center and they wanted to send us a bunch. That was the level of information. So when you called, actually, that straightened the ladder around. I think something that we need to firm up for the next time is, who do you talk to? In my personal opinion, I think it ought to be the clinician. Because there's more than just how many beds do you need, which is all the charge nurse is going to think. The doctor's going to be thinking, okay, I'm going to need to have lots of calcium gluconate. I'm going to need to have clothes. It's very important, which I got out of you, which the charge nurses wouldn't think to ask, what level of decontamination have they had? In your case, you made it right up front. So let's talk with you. Our conversation, what, 15 seconds?
Yeah,
And we were done, because all the right information was put out quickly. So I think we have to have each hospital sort of identify which person, and I would think that a clinician would be the right answer every time. And then for that conference call, so everybody else can tell,
with that as well would be on that access, whatever it is, in case of this, would be contact numbers, because I'm trying to remember a number for Samaritan's ER, which I haven't worked in Troy since I was in the Navy in 1985. So, yeah, I started when I was 4, if anybody wondering. But just a number to call and who to ask for, and be able to set that up on like a conference call would be good.
Have we ever tried using interoperability on 155/340 from hospital to hospital?
You could open up all the radios if you needed to, but there'd be probably a lot of confusion.
And then have the news listen to that?
The problem is, well, A, the news would be listening to it, but the other problem is in the middle of it, someone would be trying to get the hospital and they just keep on hitting that button, right?
Is there any option to do a, on the regular remote phone system, to put a code that dials, that sets up that conference call?
That is a ridiculously cool idea that should be looked into as part of the new remote phone
You can have a
system.
911 as the hospital code you want, and you get all the regions one. And then when it's going on in Troy and I'm out in Nellis and I can listen for 10 seconds to realize this definitely does not involve me, I have a choice to hang up. But at least that takes the searching on your phone for the list and dialing all the numbers and setting up a conference call versus the computer does it and it dials all the hospitals automatically.
The other option is that there actually is a regional, that the HOC uses all the time, is a regional call down number. Whether or not that can be used emergently to set up a conference call, because that's what actually dials out the HOC in the first place. So that number could be used, because any HOC member can post a message to that, and you could set it up as, you know, every 15 minutes, every 30 minutes during an event to do an update. And that at least would keep the administrators off the charge nurse and the clinician, because the administrators would get the update. And I think the charge nurse and the clinician both need to be involved in the ED, both to move patients and make sure they have the right resources available. So a couple of different options. Interesting ideas.
Just as a final note, I do want to say that I want to thank all the charge nurses and all the clinicians we spoke to at all of the facilities were extremely helpful. So if you take that back to your individual hospitals, no one gave us a hard time. Everybody tried to do as much as they could for us. So we do appreciate it.
And most importantly, everybody ended up being well.
Yeah.
Well, I did, just to tell you about the one I ended up admitting, it was a nice stress test. Had EKG alterations, flipped T's laterally.
Just going forward, for any dispatch center that calls, who should they ask for? I think that needs to be decided.
And that, as of right now, unless we change something else, should remain the charge nurse. I think the clinician should get involved in terms of what types of resources, but most of the time it's just gonna be, hey, how many patients can you take? And I wanna get onto the next phone call, not I wanna wait for the next person to get to the phone. But some of these will require more. This one's different than the, 30 kids on a school bus.
I believe this is an open agenda item. Someone has to sort of own this and put this together and figure out the method to conference call this. Because that way you can conference in your charge nurse and physician all together.
Yeah.
And then based on what the other hospitals say, one hospital who said, yeah, I can take 6, might go, okay, I'll do 8.
Or 3 critical, 3 green.
Yeah, you can play with it based on how busy everybody else is.
The other question is what happens if you have 2 hospitals on the line at the same time? Well, if they're gonna take 3, I'm gonna take 2.
I mean, one other thing this brings up is there are a lot of chemicals out there, we have no idea that they exist in these particular buildings.
Or what they do with each other.
Right, and that's sort of a little worrisome. And I'm just thinking, Jay and I were talking about down at the industrial park, what's down there. And this is a building that probably, as in a community, nobody would ever thought there'd be an issue with.
Right. Well, we'll all think back, what, a year and a half to the cyanide being moved in the Port of Rensselaer and what that led to everybody getting a little bit excited about over there. The potential. We'll note that industry was actually supposed to donate several cyano kits to regional hazmat response. and they didn't. So, unfortunately, that never occurred.
One thing I will say as well is, having dealt with this stuff at the level I have for the last year or so, never take it strictly from the manufacturer, the information. Always back it up elsewhere, because there's a certain amount of minimalism that comes in with it. They work with it every day, and they may not know the parameters with which we're looking at it. But I think that's a key thing.
It's very important. The other thing I think that's really important for everybody to remember is our toxicologists are always available. We always have one on call. They are extremely responsive to a phone call, and frankly, they're utterly fantastic. So Dr. Boyd, Dr. Oakes, Dr. Long, we actually have another toxicologist joining us in January, I believe. So lots of resources there, which is fantastic.
What? The operator or the transfer center?
If you call the operator or the transfer center, they actually all take calls directly to their phone, so it's not a pager system, so
Yeah.
don't let them hang up on you.
Okay.
Stay on the line with them, and they will connect you right to their cell phone.
Yeah.
Why did they condemn the equipment? The floor testing should be really clean.
Well, there was a mixture of other stuff as well. They'll get with one chemical, they will clean it, the manufacturer will clean it, test it, and send it back out. With a mix of chemicals, they don't know what's permeated, what they do together, and so forth. So it's all condemned. And Green Island, the host company has to pay for replacement, so there may be a toll on the Green Island Bridge, so.
So you're saying the tax cap is going to be blown in the village of Green Island?
I'm saying it's gonna go higher than that drawbridge.
Yeah, right?
Isn't that under insurance and everything?
Yes, insurance will cover it.
Insurance is
Yes,
gonna cover this, right?
insurance
So-
does cover it, yeah.
Okay.
A lot of it will go back to the company.
Yeah.
Fire.
It's about $3,000 a set though, so it's not a,
Then 20, how many cents?
not a small.
30 cents?
30 cents.
That's with SCBA as well, right?
Well, that's SCBA's, that's hose, any hose they used, all that stuff is.
So you're looking at $10,000 a person.
Probably, all
Without
said and done.
apparatus equipment.
Plus hospital bills, plus,
Plus what it cost to pick up the equipment to get rid of it.
and $1 a person per CD.
Plus, right.
I would like to point out, though, that Adam was free, so. there you go.
I drove by.
I've heard that about it.
Daddy.
Since we're talking about communication, and I didn't see it on the agenda this month, the LifePak 5 modems, where's that sit?
LifePak 5 modems
LifePak
are
15
not going to be
modems.
purchased.
LifePak 15 modems.
But clear.
I used to love those paddles.
Dr. Bosco actually just made some great comments on the letter that's going out to the hospitals. We already have, Kevin, correct me, what was it, $15,000? $15,000 is being committed from the region. $10,000 is coming from the Heart Association. Albany Med is already in. They're debating whether they're going to be in for $20,000 or $25,000 to support this. Dr. Bosco's suggestion was actually that we hit both the PCI facilities and the non-PCI facilities up to see if we can get some contributions. We were going to tease around some ideas further in terms of best way to approach that and then get that letter out to the institutions.
How much do we need?
So about $100,000, between $100,000 and $120,000 would be very comfortable to make sure we can cover this well.
And that's just to go to 3G? Is that the 3 or the 4?
That's to go to 3, which is the only one that's available. There is no 4G modem. There is no 4G modem available. So goal would actually be we give everybody the replacement modem this time with a couple of very clear ramifications. Number one, you transmit your EKGs and you participate in the Mission Lifeline system, and that when these age out, you are responsible for participating in and replacing these. So this is a one-time replacement, and you're responsible for the data costs.
We should make that clear in the letter too.
Yeah. Yeah.
That's a good point.
Yeah, I think so. I think you're right.
I know it's probably far-fetched, is there a window for sunset on the 3G?
Oh, I'm sure about 15 minutes after we buy them.
Yeah.
Don't know, have any idea what it is yet. I asked and was told we don't know. We don't know, so. Hopefully by then we'll all be using Wi-Fi in the hotspots that are in all of the ambulances and probably in our watches.
They'll be sitting on a beach somewhere in Key West.
You're probably right. All right, anything else from anybody?
Any more reports of small catastrophes regarding the new C-spine issues? Or we just had a little flurry at the beginning and that was that?
All I've heard is a little flurry at the beginning, and now everything seems to have settled down nicely. Anything for anybody else?
In terms of what? Missed protocols or?
Basically,
Hurt
inappropriate use
patients.
of the protocols, creating rather large misses. I mean, somebody who very clearly, based on PCR, was documented severely intoxicated, fell down a flight of stairs, not collared, not boarded. You look at the CT scan, it's like that's between the vertebrae.
We haven't had outcomes. We've had people that would, I think, based on the protocol, meet criteria for immobilization that have come to the med as traumas that have not been immobilized. But it's like finding a needle in a haystack because the number of those injuries are slim to none anyways. This is the whole argument about this. And I will try very hard to stay off my soapbox, but this is the whole argument behind this in general, is that when, you don't see those outcomes, boards or no boards. So to find those are minimum. I think there have been a number of, so we had one where there was a fatality in one of the vehicles. Person with some actually low back pain did not get boarded, which I think based on criteria, if I'm reading it correctly, would meet criteria for a back board.
Would meet criteria for a collar. not
Yeah,
a
for a
board.
collar, they aren't gonna be boarded, period.
Well,
Then we'll use them
yeah.
for boards to transfer them from A to B, but we're
Right,
not gonna
okay,
transfer
so
them
they're
on
supposed to
board.
be transferred on the board and then taken off, whatever, however you wanna put it. No board was used at any time during the, so, but there was no injury to the spine at that point.
I mean, the only thing I can bring up is, I haven't been on a call recently where we used a board to bring the person out of the car. It became more of an issue trying to get them off the board than just transporting them on the board. And it would have caused a lot more discomfort to the patient to try and get them off the board.
Yes.
So that's one thing I think folks need to kind of be careful about if they're giving providers a hard time about taking them off.
Well, we made it as clear as possible in that advisory that if a patient for their care is better off to remain on a board, they should be left on the board. The Department of Health wasn't clear about that, as we would have preferred, that the most important thing is to make sure we're taking care of the patient in front of us, not to worry about whether or not there's gonna be a board there.
Right, I mean, I think the problem was that providers were all concerned that we're gonna show up at the hospital with somebody on a board. It's like, no, that's fine. We can take the person on the board, that's okay, we don't have to strap them down, but we're not gonna go through all sorts of different maneuvers to try and get them off this board when it's gonna take time to make them more uncomfortable.
Big scoops went the way of mass pants and leeches will be coming back again. It's very viable with this.
I kept my
Leeches are back.
We got scoops on them.
I had an incident last week where I had a nurse practitioner lecture me in the middle of Route 9 that I had to put this person on a backboard. And it was interesting because she told me I was going to be sued and all sorts of other stuff. So it's going to take a while for it to filter down to the non-EMS population, but she was adamant that I had to put this person on the backboard, and I'm like, I'm sorry.
That's what the knees are for.
Yeah. Do it anymore.
Well, I will say, though, thank you for not calling me and handing her the phone. Very nice of you. Ray, did you have something else?
I was just a similar thing, football game. Physician, trainer was fine with it. Physician from the stands, same thing. You have to do this, you have to.
Yep.
They just did it and said, we're not gonna fight in the middle of, the football field here.
This was in the middle of Route 9. I wasn't arguing.
That's the biggest issue.
Yeah, my stretching, let's go.
2010, when the CPR protocols changed, right? You went from 15 to 30, you were like, no, you gotta keep, stop, no, keep going. Thought you were screwing up.
Takes a while.
Takes 5 years, I guess, right? What does that
It'll
study
change
say?
by
5 years?
5
to-
years.
It's gonna take 5 years. Exactly. Okay.
Change it again.
What?
Just try to change it.
And then it'll change again, exactly.
Yeah.
Anything else? All right, well, thank you all. Motion to adjourn?
Hold on,
Hey.
stand by.
Oh,
Just
Bruce,
quickly, what happened with the teller relocation and Tylenol? Anything?
say that again?
The teller relocation from this location
Still,
up for
still
discussion?
both remain in discussion at the collaborative
So
protocols
they're
group.
still in discussion?
Yep.
And you talked to DOH about the Capella?
No.
Okay.
We'll bring it to the DOH's attention when it's time to bring it to the DOH.
Is he sworn to secrecy or anything?
We should.
Yeah, really.
We should.
You want a blood oath.
All right, thank you all.
Thank you. I sent you an email with that cooler information. Thank you. We can hear back from you and then we'll go from there.
Shows mortality medicine, but that's not why we do that.